Мгм. Mhm. Hello, dear student. Today we are continuing gastroenterology, but in according with coronavirus pandemic, lecture changed to online format. And today's topic dyspepsia and chronic gastritis. And let's start. What is dyspepsia? Dyspepsia symptoms include a constellation of upper gastrointestinal complaints such as belching, postprandial fullness, early satiety, epigastric pain, and epigastric burning. Functional dyspepsia is diagnosed when an organic etiology for the symptoms is not identified. Dyspepsia secondary to organic disease. Although there are several organic causes for dyspepsia, the main causes are peptic ulcer disease, gastroesophageal reflux, medication, non-steroid anti-inflammatory agents for the most common offender, and gastric malignancy. Although gastric cancer as a cause of dyspepsia is a concern for both healthcare providers, it is uncommon in North America. Peptic ulcer disease. Upper abdominal pain or discomfort is the most prominent symptom in patients with peptic ulcer. Although discomfort from ulcer is usually centered in the epigastrium, it may occasionally locate to the right or left upper quadrants. While classic symptoms of duodenal ulcer occur when acid is secreted in the absence of a food buffer, 2 to 5 hours after meals or on an empty stomach. Peptic ulcer can be associated with food-provoked symptoms and thus the utility of using symptoms related to food ingestion to predict the presence of an ulcer is unreliable. Peptic ulcer can also be associated with postprandial belching, epigastric fullness, early satiation, fatty food intolerance, nausea, and occasional vomiting. Next, gastroesophageal malignancy. Gastroesophageal malignancy is an uncommon cause of chronic dyspepsia in the Western Hemisphere, but incidence is high in patients of Asian, Hispanic, or Afro-Caribbean extraction. The incidence of gastroesophageal malignancy increases with age. When present, abdominal pain tends to be epigastric, vague, and mild early in the disease, but more severe and constant as the disease progresses. In addition, other symptoms and signs typically evolve with disease progression: anemia, fatigue, weight loss. And next, biliary pain. Classic biliary pain is characterized by episodic intense dull pain located in the right upper quadrant, epigastrium, or less often substernal area that may radiate to the back. particularly the right shoulder blade. The pain is often associated with diaphoresis, nausea, and vomiting. The pain is constant and not colicky. It is not exacerbated by movement and is not relieved by squinting, belching, bowel movements, or passage of flatus. The pain typically lasts at least 30 minutes, planning within an hour. The pain then starts to subside with an anti-attack, usually lasting then 6 hours. Next, drug-induced dyspepsia. Non-steroid anti-inflammatory drugs and cyclooxygenase 2 selective inhibitors can cause dyspepsia even in the absence of peptic ulcer disease. Other drugs that have been implicated in drugs-induced dyspepsia include calcium channel blocker, methoxantins, alendronate, orlistate, potassium supplements, acarbose, dabigatran, iron, vitamin D, selective serotonin reuptake inhibitors, sildenafil, and certain antibiotics. And other causes. Celiac disease and chronic pancreatitis may rarely present with dyspepsia alone. Other rare causes for dyspepsia include infiltrative diseases of the stomach, diabetic radiculopathy, metabolic disturbances, hepatoma, steatohepatitis, celiac artery compression syndrome, superior mesenteric artery syndrome, abdominal wall pain, and intestinal angina. And what is functional dyspepsia? Functional or idiopathic or non-ulcer dyspepsia require exclusion of other organic causes of dyspepsia. It is defined by the presence of the one or more of the following: postprandial fullness, early satiation, epigastric pain or burning, and no evidence of structural disease to explain these symptoms. The pathophysiology, diagnosis, and management of functional dyspepsia are discussed in detail separately. And functional dyspepsia is defined by Rome 4 criteria and subclassified into postprandial distress syndrome and epigastric pain syndrome. And criteria for functional dyspepsia. First, presence of more than one symptom of postprandial fullness, early satiety, epigastric pain, or epigastric burning. And second, no evidence of structural disease that could explain these symptoms. And postprandial distress syndrome met in 38%, and epigastric pain syndrome met in 27%, and both this syndrome met in 35%. And what symptoms for postprandial syndrome? Early satiety, bloating, nausea, vomiting, and decreased appetite. And symptoms for epigastric pain syndrome. First, epigastric pain, and second, epigastric burning. Next, etiology of functional dyspepsia. First, gastric neuromuscular dysfunction. Gastric neuromuscular dysfunction, including delayed gastric emptying, impaired gastric fundus relaxation with blunting of postprandial accommodation, and altered gastric mechanosensitivity, has been of particular interest in this area. Second, etiology factor, psychological distress. Psychological distress has been associated with dyspepsia, with research showing both that distress and anxiety can precede symptoms and that symptoms can induce distress and anxiety. Thus, a bidirectional gut-brain pathway mechanism has been proposed. Third, etiology factor, duodenal acid exposure, dysmotility and inflammation. There is preliminary evidence concerning the presence of increased postprandial duodenal acid exposure in functional dyspepsia patients with prominent nausea symptoms. In addition, duodenal motility and bolus clearance impairment have been induced by instilling acid into the duodenum, raising concern that duodenal acid-driven pathology may contribute to dyspepsia symptoms in a subset of patients. There is growing evidence regarding the role of duodenal inflammation and duodenal eosinophilia in functional dyspepsia. Duodenal inflammation, and in particular duodenal eosinophilia, has been seen in up to 40% of patients with functional dyspepsia. And in this table, you see alarm future. And what is alarm futures for dyspepsia? Unintentional weight loss, new or progressive dysphagia, adenophagia, persistent vomiting, unexplained iron deficiency anemia, palpable mass or lymphadenopathy, family history of upper gastrointestinal malignancy, and childhood spent in a country with high risk for gastrointestinal malignancy. And diagnostic for dyspepsia. For definition, functional dyspepsia is diagnosed in the absence of an organic etiology for the dyspepsia symptoms. As outlined previously, patients with functional dyspepsia report a range of symptoms that can vary greatly in severity, and symptoms are not a reliable way for differentiate organic from functional dyspepsia. Thus, the goal of evaluation is to rule out organic etiologies for the patient's symptoms. Evaluation is based on patient age, presence of alarm future, severity of symptoms, risk of malignancy, and physical examination finding. And patient under age 60 years without alarm future should undergo Helicobacter pylori testing via stool antigen testing or urea breath test, followed by treatment and eradication. Confirmation is testing is positive for active infection. It is important to ensure that patients undergoing testing do not take a proton pump inhibitor (PPI) for 4 weeks prior to testing, and PPI use can cause a false negative test result. And what about treatment? Helicobacter pylori eradication. Although Helicobacter pylori associated dyspepsia is not technically considered under the umbrella of functional dyspepsia, Helicobacter pylori infection should be treated and confirmation of eradication should be performed if clinically indicated. Helicobacter pylori is identified in approximately 5% of dyspepsia cases. Next, acid reducing therapy. PPI therapy is considered first-line therapy for functional dyspepsia. However, studies have shown PPI therapy to be effective in treating functional dyspepsia in only 14% of patients. Next, treatment neuromodulator. If PPI therapy is ineffective or provide inadequate relief, guidelines by the American College of Gastroenterology and Canadian Association of Gastroenterology recommend a trial of neuromodulator medication. Next, treatment prokinetics and fundus relaxing therapies. The effectiveness of prokinetic agents to treat functional dyspepsia is unclear. The potential benefit of prokinetics was supported by a meta-analysis that demonstrated benefit with thizacloprid, domperidone, and etioprid therapies. And psychological therapies. 58 patients with functional dyspepsia were randomized to either medical therapy alone or with psychotherapy, with great improvement in dyspepsia-related quality of life scores in the combination therapy group. Okay, and functional dyspepsia treatment algorithm. First of all, you provide Helicobacter pylori testing, and if you receive positive result test, you have only single step and treat and assess response. If you received negative result, you have several steps, and first step, consider 4-week trial of a moderate dose proton pump inhibitor. If you see poor response, you continue, and your second step, consider herbal or neuromodulator therapy. If you saw poor response again, continue, and third step, consider prokinetic or fundus relaxing agent. Okay, and second part of this lecture is chronic gastritis. And what is chronic gastritis? The term gastritis was first used in 1728 by the German physician Georg Ernst Stachel to describe the inflammation of the inner lining of the stomach, now known to be secondary to mucosal injury, cells damage and regeneration. In the past, many considered gastritis a useful histological finding, but not a disease. This is changed with the discovery of Helicobacter pylori by Robin Warren and Barry Marshall in 1982, leading to the identification, description, and classification of a multitude of different gastritis. And the Sydney system for classification of gastritis. It incorporates etiology, topography, and the morphological features to be documented when reading and reporting endoscopic gastric biopsies. The topography of gastritis in the core of the classification. Etiological hints can be added as a prefix and the graded variables as suffix. Typical examples would be Helicobacter pylori, pangastritis, severely active with mild panatrophy. Continue about classification and type of gastritis. And non-atrophic. Next type, atrophic, but divide on two: autoimmune and multifocal atrophic. And special form. And what is special form? Chemical, radiation, lymphocytic, non-infectious granulomatous, eosinophilic, and other infectious gastritis. What about etiology? Helicobacter pylori and other factors. Autoimmunity, dietary, environmental factor, chemical irritation, bile, non-steroid anti-inflammatory drugs, and other agents. Radiation injury, idiopathic immune mechanism, gluten, drug, Crohn's disease, sarcoidosis, granulomatosis, foreign substances, idiopathic, food sensitivity, other allergies, bacteria, viruses, parasites. And what about gastritis synonyms? Superficial, diffuse antral gastritis, chronic antral gastritis, interstitial follicular, type B, type A, diffuse corporal, pernicious anemia associated, type B, type AB combined, environmental, metaplastic, reactive, reflux, non-steroid anti-acid drugs, type C, varioliform, celiac disease associated, isolated granulomatous, allergic, and phlegmonous. And in clinical practice, gastritis staging is done using The operative link of gastritis assessment, staged system for reporting gastric histology. Gastritis staging combines the atrophy score, which is determined by biopsy, and the atrophy pathography, which is determined by directed biopsy mapping. Helicobacter pylori associated chronic gastritis pathophysiology. Helicobacter pylori is the leading cause of chronic gastritis, peptic ulcer disease, gastric adenocarcinoma, and primary gastric lymphoma. First described by Marshall and Warren in 1983, Helicobacter pylori is a spiral gram-negative rod that has the ability to colonize and infect the stomach. The lipopolysaccharides of the outer membrane of Helicobacter pylori are a major component of its ability for colonization and persistence. The bacteria survive within the mucous layers that cover the gastric surface epithelium and the upper portion of the gastric folia. The infection is usually acquired during childhood. The virulence factors responsible for established colonization include urus, flagella, hemotaxis system, and adhesins. With increasing antibiotic resistance, this virulence factor provides alternative drug or vaccine targets for Helicobacter pylori eradication and prevention. The virulence factor responsible for immune escape help Helicobacter pylori escape from host immune clearance and allow its persistence in the human stomach. Once present in the stomach, the bacteria passes through the mucous layer and becomes established in the luminal surface of the stomach, causing an intense inflammatory response in the underlying tissue. The presence of Helicobacter pylori is associated with tissue damage and the histologic finding of both an active and chronic gastritis. The host response to Helicobacter pylori and its bacterial product is composed of T and B lymphocytes denoting chronic gastritis, followed by infiltration of the lamina propria and gastric epithelium by polymorphonuclear leukocytes, and eventually phagocytize the bacteria. The presence of polymorphonuclear leukocytes in the gastric mucosa is diagnostic of active gastritis. An increased duodenal acid load may precipitate and wash out the bile salts, which normally inhibit the growth of Helicobacter pylori. Progressive damage to the duodenum promote gastric folia metaplasia, resulting in sites of Helicobacter pylori growth and more inflammation. This cycle renders the duodenal bulb increasingly unable to neutralize acid entering from the stomach until change in the bulb structure and function are sufficient for an ulcer to develop. Helicobacter pylori can survive in areas of gastric metaplasia in the duodenum, contributing to the development of peptic ulcer. When the infection is cured, neutrophil infiltration of the tissue quickly resolves, with slower resolution of the chronic inflammatory cell. Paralleling the slow resolution of the monocytic infiltrate meal stimulated gastrin secretion return to normal. Various strains of Helicobacter pylori exhibit difference in virulence factor, and these differences influence the clinical outcome of chronic Helicobacter pylori infection. People infected with Helicobacter pylori strains can secrete the vacuolating toxin A, are more likely to develop peptic ulcers than people infected with strains that do not secrete this toxin. Helicobacter pylori associated chronic gastritis progresses according to the following two main topographic patterns, which have different clinical consequences. Antral predominant gastritis. This is characterized by inflammation that is mostly limited to the antrum. Individuals with peptic ulcers usually demonstrate this pattern. Next, multifocal atrophic gastritis. This is characterized by the involvement of the corpus and gastric atrium with progressive development of gastric atrophy, loss of the gastric glands, and partial replacement of the gastric glands by intestinal type epithelium, intestinal metaplasia. Individuals who develop gastric carcinoma and gastric ulcer usually demonstrate this pattern. And variant of chronic gastritis. And first variant which discuss is autoimmune atrophic gastritis. Autoimmune atrophic gastritis is associated with serum antiparietal and anti-intrinsic factor antibodies. The gastric corpus undergoes progressive atrophy. Intrinsic factor deficiency occurs and patient may develop pernicious anemia. The development of chronic atrophic gastritis, sometimes called type A gastritis, limited to corpus, fundus, mucosa, and marked diffuse atrophy of parietal and chief cells, characterized autoimmune atrophic gastritis. In addition to hypochondria, autoimmune gastritis is associated with serum antiparietal and anti-intrinsic factor antibodies that cause intrinsic factor deficiency, which in turn causes decreased availability of cobalamin, eventually leading to pernicious anemia in some patients. Hypochondria induces G cell hyperplasia, leading to hypergastrinemia. Gastrin exerts a trophic effect on enterochromaffin-like cell and is hypothesized to the one of the mechanisms leading to the development of gastric carcinoid tumor. In autoimmune gastritis, antibodies are directed against at least 3 antigens, including intrinsic factor, cytoplasmic, and plasma membrane antigens. There are 2 types of intrinsic factor antibodies, type 1 and type 2. Type 1 antibody prevents the attachment of vitamin B12 to intrinsic factor, and type 2 antibody prevents attachment of the vitamin B12 intrinsic factor complex to ileal receptors. T-cell lymphocytes infiltrate the gastric mucosa and contribute to the epithelial cell destruction and resulting gastric atrophy. Next variant of gastritis is granulomatous gastritis. Granulomatous gastritis is a rare entity. Causes of granulomatous gastritis can be divided into infectious diseases, non-infectious diseases, and idiopathic, which are observed in approximately 25% of cases. Tuberculosis may affect the stomach and cause caseation granulomatous. A granuloma is an organized aggregation of combined histolytic, lymphocytic, and plasmacytic infiltrates. When this organized collection of cells is identified in the stomach, it is referred to a granulomatous gastritis. Granulomatous gastritis is a type of chronic gastritis and can be subclassified based on the etiology into infections, non-infections, and idiopathic granulomatous gastritis. Non-infection disease are the usual cause of gastric granulomas. These include Crohn's disease, sarcoidosis, and isolated granulomatous gastritis. Crohn's disease demonstrates gastric involvement in approximately 33% of the cases. Granulomas have also been described in associated with gastric malignancies, including carcinoma and malignant lymphoma. Sarcoid-like granulomas may be observed in people who use cocaine, and foreign material is occasionally observed in the granuloma. And next, gastritis in patients who are immunosuppressed. Cytomegalovirus infection of the stomach is observed in patients with underlying immunosuppression, but it remains unclear whether cytomegalovirus gastritis promotes the development of gastric carcinoma. Histologically, a patchy, mild inflammatory infiltrate is observed in the lamina propria. Typical intranuclear eosinophilic inclusions and occasionally smaller intracytoplasmic inclusions are present in the gastric epithelial cells and in the endothelial of mesenchymal cells in the lamina propria. Severe necrosis may result in ulceration. Other infections causes of chronic gastritis in immunosuppressed patients include the herpes simplex virus, which causes basophilic intranuclear inclusions in epithelial cells. Mycobacterial infections involving Mycobacterium avium intracellular and characterized by diffuse infiltration of the lamina propria by histiocytes, which rarely from granulomas. Next, gastritis is lymphocytic gastritis. Lymphocytic gastritis is a type of chronic gastritis characterized by dense infiltration of the surface and foveal epithelium by T lymphocytes as associated chronic infiltrates in the lamina propria. Because its histopathology is similar to that of celiac disease, lymphocytic gastritis has been proposed to result from intraluminal antigens. High anti-Helicobacter pylori antibody titers have been found in patients with lymphocytic gastritis, and in limited studies, the inflammation disappeared after Helicobacter pylori was eradicated. Next gastritis is eosinophilic gastritis, and large number of eosinophils may be observed with parasitic infection such eosinophilic gastritis can be part of the spectrum of eosinophilic gastroenteritis. Although the gastric antrum is commonly affected and can cause gastric outlet obstruction, this condition can affect any segment of the gastrointestinal tract and can be segmental. Patients frequently have peripheral blood eosinophilia. In some cases, especially in children, eosinophilic gastroenteritis can result from food allergy, usually to milk or soy protein. Eosinophilic gastroenteritis can also be found in some patients with connective tissue disorders, including scleroderma, polymyositis, and dermatomyositis. And chronic gastritic symptoms or clinical presentation. Helicobacter pylori chronic gastritis, which is usually asymptomatic but may manifest as epigastric pain, nausea, vomiting, anorexia or satiety or weight loss. Symptoms may occur with the development of complications of chronic Helicobacter pylori gastritis, which include peptic ulcer, gastric adenocarcinoma, and mucosa-associated lymphoid tissue lymphoma. The clinical manifestation of autoimmune gastritis are primarily related to the deficiency in cobalamin, which is not adequately absorbed because of intrinsic factor deficiency resulting from severe gastric parietal cell atrophy. The disease has an insidious onset and progresses slowly. Cobalamin deficiency affects the hematological, gastrointestinal, and neurological system. In multisystemic diseases, specific symptoms related to gastric involvement may be minor. caseating granulomas secondary to tuberculosis may be found in the absence of a lung disease in patients who are malnourished, immunosuppressed, and alcoholic. Patients with Crohn's disease and gastric involvement may report abdominal pain, nausea, and vomiting. Gastric involvement in Crohn's disease is almost invariably associated with intestinal disease, and intestinal manifestation predominate. And look on the picture, you may see main symptoms of gastritis, belching, heaviness, vomiting, flatulence, bloating, and pain. And physical examination in uncomplicated Helicobacter pylori associated atrophic gastritis, clinical findings are few and non-specific. Gastric tenderness may exist. If gastric ulcer coexists, Gaiac-positive stool may result from occult blood loss. Bad breath and abdominal pain or discomfort may occur, with bloating associated with bacterial overgrowth syndrome. Physical findings may result from the development of pernicious anemia and neurological complications in patients with autoimmune atrophic gastritis with severe cobalamin deficiency. The patient is pale and has slightly icteric skin and eyes. The pulse is rapid and the heart may be enlarged. Auscultation usually reveals a systolic flow movement. And on this slide, on the left, you may see picture, white picture, and that's all. But in real, this link with video, and if you copy this link and use YouTube, you may see video with physical examination in patient with chronic gastritis. Laboratory studies. A rapid urease test should be done on gastric biopsy tissue. Helicobacter pylori bacterial culture of gastric biopsy tissue is usually performed in the research setting or to assess antibiotic susceptibility in patients in whom first-line eradication therapy failed. Atrophic gastritis may be assessed by measuring the ratio of pepsinogen 1 to pepsinogen 2 in the serum. Pepsinogen 1 and pepsinogen 2 are synthesized and secreted by gastric chief cells. After being secreted into the gastric lumen, they are converted into proteolytic active pepsins. The level of pepsinogen 1 in the serum decreases as gastric chief cells are lost during gastric atrophy, resulting in a decreased pepsinogen 1 pepsinogen 2 ratio. Gastric carcinoma occurs, especially the intestinal type, usually in association with severe atrophic gastritis. Measuring the level of pepsinogen 1 and pepsinogen 2 and the pepsinogen 1 and pepsinogen 2 ratio in the serum is useful as screening for atrophic gastritis and gastritis cancer. Gastric cancer is a region with a high evidence of these diseases. The following test results suggest the diagnosis of autoimmune gastritis. Anti-parietal and anti-intrinsic factor antibodies in the serum. Next are chloridria, both basal and stimulated, and hypergastrinemia. Next, low serum cobalamin, vitamin B12 level. And next, possible abnormal result on Schilling test. Endoscopy. Magnifying endoscopy is helpful for analyzing the subepithelial microvascular architecture as well as the mucosal surface microstructure without tissue biopsy. Upper gastrointestinal endoscopy is essential for establishing the diagnosis of gastritis, although some studies have suggested that Helicobacter pylori infection can be determined on the basis of unique endoscopic features, particularly the presence of antral nodularity. Whether there is specific relation between Helicobacter pylori and macroscopic feature remains controversial. The endoscopic findings in chronic Helicobacter pylori infection may include areas of intestinal metaplasia. Multiply biopsy specimen should be obtained. Tissue sampling from the gastric antrum, incisor and corpus is essential to establish the topography of gastritis and to identify atrophy and intestinal metaplasia, which usually is patchy. It is recommended that biopsy samples of the gastric body and those from the antrum and incisor be submitted in separate containers for pathological evaluation. The endoscopic finding of reflux and chemical gastropathy are those of a gastric mucosa that is red or has red streaks with area of apparent hemorrhage. And look of this picture and classification of gastritis. Classification of gastritis with helping endoscopy. Picture A, small picture A is normal. Picture B, superficial gastritis. Picture C, atrophic gastritis. And picture D, intestinal metaplasia. Okay, and chronic gastritis treatment and management. Treatment of chronic gastritis can be aimed at a specific etiological agent if such an agent is known. Some entities manifested by chronic gastritis do not have well-established treatment protocols. For example, in lymphocytic gastritis, some cases of spontaneous healing have been reported. However, because the disease has a chronic course, treatment is recommended. First of all, in treatment, use diet. And what food to eat? High or antioxidant food, probiotic food, high fiber food and healthy fats and proteins. And what foods to avoid? Citrus fruit, juices, tomatoes, milk, alcohol, coffee, spicy food, and common allergens and inflammation food. And on this slide, on the left, you may see day patient with chronic gastritis, and gastritis diet chart. And pharmacotherapy for Helicobacter pylori. At first, specific recommendations for Helicobacter pylori eradication were limited to peptic ulcer disease. Antibiotics that have proven effective against Helicobacter pylori include clarithromycin, amoxicillin, metronidazole, tetracycline, and furazolidone. One is version of the traditional bismuth metronidazole tetracycline triple therapy. Three different combinations using clarithromycin have been approved, including two dual therapies consisting of 500 mg of clarithromycin 3 times daily plus either omeprazole or ranitidine bismuth citrate. The cure rates reported in the packaging literature suggests that the three combinations are similarly effective. And clinical experience has shown that the most effective of this regimen is BMT triple therapy, followed by ranitidine, bismuth citrate, plus clarithromycin, and then omeprazole plus clarithromycin. And what is triple therapy with indicated adult dosing? Twice daily PPI or ranitidine bismuth citrate triple therapy includes the following: lansoprazole 30 mg or omeprazole 20 mg or ranitidine bismuth citrate 400 mg orally twice daily. Clarithromycin 500 orally twice daily, and amoxicillin 1000 mg or metronidazole 500 orally twice a day. And what is quadruple therapy with indicated adult dosing? Quadruple therapy with Helicobacter pylori infection typically include the following: PPI, lansoprazole 30 mg or omeprazole 20 mg orally twice a day, tetracycline 500 mg 4 times a day, bismuth 120 mg orally 4 times daily, and metronidazole 500 mg orally 3 times a day. And evaluate eradication at least 4 weeks after beginning of treatment. Eradication may be assessed by means of non-invasive methods such as a urea breath test or the stool antigen test. Follow-up may be individualized depending on the finding during endoscopy. Treatment for chronic gastritis. Once atrophic gastritis is diagnosed, treatment can be directed. And first, to eliminate the causal agent, which is possibility in cases of Helicobacter pylori associated atrophic gastritis. Second, to correct complication of the disease, especially in patients with autoimmune atrophic gastritis who develop permission. Anemia in warm vitamin B12 replacement therapy is indicated. Or third, to attempt to reverse the atrophic process. If Helicobacter pylori is identified as the underlying cause of gastritis, subsequent eradication now in almost generally an accepted practice. Currently, the most widely used and efficient therapies to eradicate Helicobacter pylori are triple therapies and quadruple therapy. In both cases, the best results are achieved by administering therapy for 14 days. Although some studies have recommended the duration of treatment of 7 days. The accepted definition of cure is no evidence of Helicobacter pylori 4 or more weeks ending the antimicrobial therapy. Thanks for your attention. If you have questions, please leave comment under this video or page of our department in Facebook, and we try to answer on your questions or maybe discuss. What about next lecture? Unfortunately, next lecture will be cancelled due to official Ukrainian holiday, and we will meet with you 2 weeks. Thanks for your attention.